connect me, please. Thank you very much, everyone, and it's always a pleasure to be here. This is a fantastic meeting. I'm really glad that it's called Moorfields Thessaloniki Ophthalmica meeting. I've been coming here, I think this is my third time, and I thoroughly enjoy the teaching and training, and I learn a lot from being here. So thank you to Paris, Miltos, and everyone for inviting me and putting up with me once again. Okay, great. So I was asked to talk about preoperative assessment and refractive surgery technique, a practical guide on decision making. The first thing that is worthwhile to know is that we've got lots of different options in refractive surgery, but what we need to remember is that we need to customize them because there is no surgery that fits all of our patients. Different patients have got different suitability and needs, and the surgery is not always black and white. Sometimes can be that you can choose one procedure, but sometimes you have to think about which procedure could you choose and which one could be the best, and this is based really on your experience. This just shows you the different options that we have in terms of laser vision correction, LASIK, SMILE, surface ablation of different type from epi-LASIK to trans-PRK, phakic IOL, especially for the higher level of myopia and hyperopia, and also for our older patients that seek presbyopic correction, refractive lens exchange with a vast number of different multifocal and toric lenses. And this is what we call at Moorfields the rough guide to refractive surgery, showing that the different procedures fit different kind of refractive error, but then you need to take into account the physical characteristic of the patients. For instance, with LASIK, usually works well for myopia up to -8, hyperopia up to +4 with the correct laser, and astigmatism up to 4 diopter. LASIK indication are a little bit expanded because really we use mainly surface ablation where LASIK is not possible because I'm pretty convinced that it's much safer in terms of post-LASIK post-refractive surgery ectasia risks. So in cornea that are thinner but otherwise normal, in higher myopic refractive error, or if the pentagram looks a little bit unusual, I would always prefer to choose a surface ablation versus LASIK or SMILE for the sake of avoiding the risk of long-term problems such as corneal ectasia. Implantable contact lenses are really useful in the higher degree of myopia, but you have to remember the limitation. So before talking about implantable contact lens, you must have your pentagram set on ACDI, anterior chamber depth internal, not external, because the internal needs to be at least 2.8 millimeter for myopic treatment with ICL and 3 millimeter for hyperopic treatment. So do not discuss those unless you've got all the data. Otherwise, it looks strange to the patient. Tell ICL, and then you realize that even a high myop can have a relatively shallow anterior chamber, and the ICL is not an option. Now, refractive examination. This is key because you need to have a good optometrist, or if you don't, because it varies from country to country. In the UK, we are lucky because this job is done for us by fantastic optometrists. You need to be able to refract your patient precisely. And remember, take into account the BVD, especially for the high myops, which is distance from the glasses to the cornea, because few millimeter will have quite an impact on the highly myopic prescription. So, ocular surface is key in any kind of refractive surgery. You want to make sure not just for the laser, but also for RLE that the surface is good. So, have a look, use fluorescein, and if in doubt, treat the ocular surface heavily before considering any laser vision correction. Pentacam, wavefront scan, pupil size. Key, especially for ICL and RLE, because those are the cases where it's more likely that patients with large pupil size will get more halos and glare. And they can be easily forgiven and forgotten, but only if you explain to the patient and you show them things before. Counseling is key, and you should always provide extensive counseling on complication, risks, and side effect of the surgery, outcomes. Explain to the patient it's not always possible to achieve 100%, and what I tell my patient, the rule of thumb, is there is always the possibility of a 10% error. If you are -3, should be less of an issue because 10% is ±0.3, but if you are -10, 10% is ±1 or more, and therefore there will be more risks of needing a retreatment, which we normally offer free of charge at Moorfields. Written information and consent are key. Pentacam, I think at the moment is still the gold standard in refractive surgery simply because it's so widely common to have a pentacam in clinic and because there are special displays that make it almost idiot-proof to understand if the patient is suitable for laser vision correction or not. Corneal curvature, look at the normality, look at the thickness, and look at the posterior cornea. This is a typical example of a pentacam. I always like to look at the refractive display because it shows me if there is any abnormality and if there is any form frust or subclinical form of keratoconus. And also we'll look at the Bellina ambrosio to look at the protrusion of the posterior cornea and the theoretical risk of corneal ectasia in the future. Remember, refraction must be stable, so make sure that your patient come to the consultation with an appropriate time of being off contact lenses. If there are doubts, always consider cycloplegic refraction because some patients will be accommodating quite a lot and you don't want to make them hyperopic after vision correction because otherwise they will hate it. And for the older patient, consider micro-monovision or blended vision and look at which eye is dominant. This is from a paper showing the contraindication to laser vision correction, but I've highlighted the other are simple, but the one that is really difficult is, look for the personality of your patient. Unrealistic patient expectation are really something that you need to be very careful because this will be your unhappy patient to come to refractive surgery for secondary gains rather than willingly wanting to have refractive surgery. Customized planning is simple, say, oh, you're -4, you can have the surgery, or +2 is easy. No, it is not, because you need to look at the eye as a whole and remember, take into account especially the curvature. With myopia, we flatten the cornea. With hyperopia, we steepen the cornea. And to keep good optics and good tear film, there is a limit at how much you can flatten or steep. So a patient is already very flat, and there are some of them is not an ideal candidate for a highly myopic treatment. And likewise, a patient has got a quite curved cornea to start with, more than 45, 46, is not ideal for hyperopic treatment because you will make that cornea even steeper, and this can cause problem with the quality of vision. LASIK, at least in the UK, is one of the commonest procedure, and what you need to understand, probably most of you do already, is the concept of residual stromal bed, which is what is left once that you have taken into account the corneal minimal central thickness, and you have removed the thickness of the flap and the expected ablation tissue that you remove. And there are variables in this, and you need to be aware of all of these to calculate it, because ideally the residual stromal bed should be a minimum of 250. I personally prefer to leave it at least 300. So briefly, imagine that you've got a patient, just for the sake of mental calculation, 33 -4, thinnest cornea is 510 micron, normal pentacam, everything, 6 mm scotopic pupil, normal case, everything is good. So sometimes you need to do a nomogram adjustment for age and sex, but most modern laser will do that for you. You must have your own nomogram. I think Bruce will talk more about that. And if you consider an ablation of 6.5 mm, the average laser will remove 58 micron. In this case, the residual stromal bed, taking into account the 110 micron flap, will be well above 300 micron. So what you need to do is have in mind this calculation when you plan your laser, if you don't do the planning before seeing the patient on the wavefront scanning machine. Risk of ectasia, like I think this is hinted before, there are two seminal papers from Randleman. One looks at the ectasia risk score. Is a paper that is relatively old, but is very useful because it shows you what are the main factors that you need to look at, which is corneal topography is key. Don't do LASIK if the corneal topography is abnormal. Amount of myopia and age of the patient. The younger the patient, the more elastic the cornea, the higher the risk of corneal ectasia. Some of us will not do LASIK in a patient that are probably below 26, 28 years of age because of the corneal elasticity. The second paper is more recent, and this is the one that looks at the PTA, which is the percentage of tissue being altered by the LASIK procedure. That's how you can calculate it. You can look at the paper, but basically if it is more than 40%, your risk of ectasia is going to be higher, and I think you should switch to a different surgical technique. And this shows you clearly cases that developed ectasia, and in retrospect, they had a PTA higher than 40. The easiest thing sometimes show you cases and what the average surgeon would do. For instance, this is a 27-year-old man that came to see me seeking refractive correction for high myopia. Great vision, quite high myopia, thin cornea. And the PTA for him was well above 40%, so not a candidate for LASIK. And if you look at this scan, thin cornea, but otherwise normal. But when you look at the Bellina ambrosio, you can clearly see, especially in this eye, that there is some abnormality. So in this case, having a deep AC, I think the best option for him would be an implantable contact lens. And that's what he had, and he did well. Now, this is a 25-year-old man with great best corrected visual acuity, but very high compound myopic astigmatism, and also anisometropia. You can see that one eye is much more myopic, the left eye, than the other. So, although the PTA is good in both eyes, the patient is young. Sometimes, it's a little bit of a struggle, especially in the UK, to tell patients about PRK, but PRK does work well, and you have to stress to the patient the slower visual recovery, and especially to men like me or younger, the problem with discomfort. Ladies are so much better in putting up with discomfort than men, so worry less about ladies than boys. Can see that the pentagram was absolutely normal, nice and thick, strong cornea, Bellina Ambrosio, completely normal. Both eyes the same. So this is what would be his residual stromal bed down there. And the PTA was more than 40. So the options here that you have is you can do LASIK or LASEK or your TICL. In this case, he decided, for the sake of a speedy visual recovery, to LASIK in one eye and LASEK in the other, where the residual stromal bed was coming close. And it was just a question of time, but both eyes have done really well. Another example. This is a very useful thing for ICL. We have a 44-year-old man who had radial keratotomy 20 years ago with a decent result, but then 10 years later he became quite hypermetropic, and he had been wearing this prescription for the last 5 or 6 years. So these patients are really ideal for implantable contact lenses because they got a deep AC, because they were myopic to start with. He came to see me for a second opinion, having seen another colleague, and advised to have collagen corneal cross-linking and RLE with toric lenses. Pentagram is all over the places after RK, but he had a very good prescription history. This is right and left eye. Yeah, nothing can make much out of it at all from the pentagram. And the only option possible were, yes, the RLE and toric, but I can't guarantee them good vision because the astigmat is relatively irregular on the cornea, whilst this refractive astigmat was completely stable, proven by prescription. Collagen cornea cross-linking, I don't know how much evidence there is that is useful post-RK, but moreover, it was not changing. It had been like that with the same prescription for the last 5 or 6 years. So what we did was toric implantable contact lenses, and has worked well. This was something like 6-7 years ago. So here you just see a quick video of how to implant a toric lens. At the time, we didn't have marketless system. So the cornea is marked preoperatively, the vertical and horizontal axis, and then we're just marking with the Mendes ring the steeper axis for the toric IOL implantation. So it's very straightforward. If you're a good cataract surgeon and you go to a couple of courses, it's really easy to pick up because it's simplified cataract surgery. So the lens is first injected inside the anterior chamber and then is gently tacked in under the iris. It needs to be a no-touch technique because you don't want to go and touch the top of the lens, being very, very thin. And in those cases, unlike myopic lenses, you need to do a peripheral iridectomy because they don't come even now with a hole, unlike the ICL that we use to correct myopia. And then the ICL is positioned in, and in this way, because his refraction allowed him 20/20 vision, he has been very happy since. Now, I know someone else will talk about laser vision complication, but remember to explain to your patient that likely they are rare. If treated, most of them can be sorted. I think the surgeon needs to have some corneal expertise, but if you listen to Bruce talk, then you will know how to treat microbial keratitis and infection. Ectasia is rare, but possible. Very briefly, these are some of my own complications. You can see flap wrinkles at higher magnification. Epithelial ingrowth is another issue, but likely is very, very rare. Again, higher magnification. And then central toxic keratopathy, which is a rare complication. I've seen only one case in my own practice, but we had a cluster a few years ago. But luckily, if you know what to do, which is sometimes do absolutely nothing, just manage the patient expectation, gets better by its own. Your first patient, how to choose it? Well, choose an easy case with a straightforward prescription, low visual demand. Avoid academics, please, because they can be a nightmare, like we all know. Outdoor type, and avoid deep set eyes. So you really don't want someone like him, because he's going to be a complete nightmare. You want someone with really open, wide eyes. So the key to success in refractive surgery is really proper planning, choosing the correct procedure, and sometimes explain to the patient that you could have procedure A or procedure B or procedure C, and discuss it with them the option, the risks and benefit to come to a conclusion. The worst that you can do, though, is make your patient to go out of your office without having chosen which procedure to do, because then he will not come back. So you explain the difference, but then you come up with a decision the very same day or at another consultation. Exclude medical contraindication, but these are easy because now we've got all the instrument, all the tools like the pentagram, etc., to make sure that we do not choose patients who are not really suitable physically, and be aware of the funny personality. Don't be afraid of asking patients, are you hypercritical? Yes, oh God, perhaps you're not a very good candidate for laser vision correction. Lots of information, counseling, and most important, at least in the UK, pay your medical insurance bills, so you are always nice and safe. Thank you very much. Of course.
2 months ago, that I had to remove a fake IOL. It's very, very, very slim, very, very thin.
Indeed.
Do you have any special tricks? Because in my hand it was fragmented quite easily. Do you use special instruments or any?
I think you need to do two things. Not your case, I'm sure, but a common mistake that people do when they go and remove an ICL, they try to fill the anterior chamber with viscoelastic under the ICL. I think that's a mistake because it's a recipe to get an iris prolapse. What you should do, you should use the same technique, which is tapping and moving the ICL from under the iris. And then, once that you put it inside the corneal incision, you need some very strong forceps, because you need to grab, and these two forceps to do a grabbing one after the other. Otherwise, what can happen is it breaks. But even if it breaks, you can regrasp it. So normally I use capsular axis forceps to pick it up in the anterior chamber and pull it out. And then I get some grooved forceps, 2 pair, and then I just pull, grab, and pull. Thank you.
Thank you very much. And I will ask Dr.